Welcome, everyone. My name is Shirley. I will be your moderator this evening. Tonight's webinar is called Ultrasound-Guided OBGYN featuring scan reviews. It's going to be a really interesting one. I'm excited to welcome Iikia Poitier as our speaker this evening. Hello, Iikia.
Hello.
Iikia is a highly influential sonographer with a passion for inspiring and impacting women. And through her expertise and the power of social media, she has created a dynamic platform, and she engages women along their health journey. So it's quite important. Before we get started, I would like to take a moment to go over some quick housekeeping. If you have any questions, please type them out in the Q&A, and we're going to hold and address the questions at the end of tonight's webinar. CE is not available for this webinar this evening. But with that said, please join me in welcoming Iikia, and thank you for being with us. I'm going to pass it over to you now.
Okay, awesome. Good evening, everyone. Just like Shirley said, my name's Iikia, and I do all things OBGYN ultrasound. It's my passion, and I love it. So we're just going to go ahead and get started. So I'm going to let you know that I'm using the MindRay model, the DC8 ultrasound machine model. So the images and the videos you see today is coming from that particular model. All right. So what are we talking about today? So we're going to talk about fibroids, all things fibroids, the different types of fibroids, IUD placements, PCOS or polycystic ovarian syndrome. We're going to talk about first trimester ultrasound, viable pregnancies, and those that aren't viable as well. We're going to talk about ectopics. We're going to talk about blighted ovum and absent fetal heartbeats, okay? All very important. All right, so different type of fibroids. We have intramural fibroids, subserosal fibroids, pedunculated fibroids, submucosal fibroids. Those four are the main types that we go by, but I also added intracavitary fibroids because I'd like to use that because it shows the difference between the submucosal and the intracavitary fibroids. It's a tad bit different in my opinion, and it gives an idea for the physician to see exactly where the fibroid is. So today we're talking, okay, so first we'll talk about intramural fibroids, okay? So intramural fibroids are benign tumors that grow within the wall without disrupting the endometrial lining and contour shape of the uterus. These type of fibroids are the most common types of uterine fibroids. Intramural fibroids are relatively easy to visualize when they are hypoechoic and well encapsulated within the myometrium. So normally when women have intramural fibroids, they don't typically have many symptoms unless the fibroids get extremely large. So that's why, we say, oh, these are the most common type, because we normally find this is kind of like an incidental finding normally. Like they come in for something else, maybe, and then we say, oh, you may be pregnant. And we say, oh, didn't you know you have a fibroid? Because, or whatever, it just wasn't giving the patient any symptoms at the time. So let's kind of look at how they look. So here's a video. This is just the uterus here. So you can see the whole uterus here. This whole area is the uterus. And right here, you can see kind of like little fibroid there. And as I sweep through, you can see, pause it. You can see a fibroid here. You can see a fibroid there and a fibroid here. Now, fibroids typically on ultrasound appear round. That's just how they are. They're always round and very uniform in its shape. And they will have shadowing on the sides of the actual shape. So if you see this circle here, this is a fibroid. And on the side here, you can see the shadowing. So that confirms that we're indeed seeing a fibroid. Now, I'm looking like sweeping through the uterus, so you can kind of see that the shape is still intact. So if you look on the outline here, you can see in the outline that the shape is exactly the same, and the fibroids are kind of just in the middle there of the myometrium. So that's how we know that this is an intramural fibroid. So I'll play the video here so you can keep seeing the clips. You can see the shadowing on the side of this fibroid. And then if you go back, the contour of the uterus looks normal. And then you can actually see a tiny little fibroid here. But like I said, it's within the myometrium. I'm going to do another sweep here, just so you can see the shadowing. 1, 2, 3. I'm looking at 3 fibroids here. And that's how we find our intramural fibroids. So moving on. So that was intramural fibroids, okay? So now we're looking at subserosal fibroids. So subserosal fibroids develop outside the wall of the uterus into the pelvis and can become very large. These types of fibroids change the shape and contour of the uterine outline. If these fibroids get too large, they can also cause the patient's abdomen to have a bloated or distended appearance. In my experience, most fibroids get pretty large, but if I had to choose one, the subserosal fibroids get extremely large. Subserosal and pedunculated fibroids, in my opinion. So once again, these fibroids, you will know because they distort the contour. They change the contour of the uterus. Unlike intramural fibroids, those are kind of inside of the myometrium. These will kind of be on the outside. So let's take a look at some images here. So here's a video here. All right. So right now we can already tell this is the uterus, this whole thing here. And as you can see the uterus, you can already see this big old fibroid right here. And if we keep looking here, you can see how it's changing the shape of the actual uterus. So you see the lining of the uterus here, and then you can see the fibroid kind of is all the way on the outside on the bottom there posteriorly. So that's how we know that this is a subserosal fibroid. So, yep. Big old fibroid there. All right. So here are some still pictures here. So I use the arrows here so you can see that the outline of the uterus is here. This is the outline. And then you see this big old fibroid there. And you can kind of see that it's outside of that lining. You can see that it's coming right from that myometrial tissue there. And even here, this is me looking midline of the uterus. And before I even do a sweep, you can kind of see that it's already showing up posteriorly there. All right, so next we have pedunculated fibroids. So pedunculated fibroids can extend laterally, possibly mimicking an adnexal mass. Differentiation of a pedunculated fibroid from a solid mass is a connecting stalk-like tissue that branches off of the myometrium. A pedunculated fibroid should always show a connection to the uterus. Large pedunculated fibroids can cause severe period pains, painful sex. Some patients complain of bloating and can sometimes feel the lump of the fibroid by feeling on their abdomen. So same thing in terms of size. They do get pretty big, like the subserosal fibroids. Now, you have to be very careful with the pedunculated fibroids because you have to make sure that you can see that it's branching off of the uterus and it's not just branching off of an ovary or it's just, just a random mass in the adnexa. You want to make sure that you show proof that it's branching off of the actual uterus. So let's take a look here. All right. So here we're looking at the uterus in a transverse plane. So this is the uterus here. And you're going to see, I'm going to start, scanning, and you can already tell something's branching off here. So there we go. We see the fibroid right there. And you can see a little bit of calcification there. But if you look closely where the uterus is and this little band here, that's the stalk-like area that I'm talking about. That's what you want to see when you're trying to prove that this is a pedunculated fibroid. There we go. You see, I'm kind of pointing at it there. That's the stalk that we want to see when we're trying to prove that this is a pedunculated fibroid. It's branching off of the uterus. And this is in a pregnant patient, actually. We just end up finding that. You can see it's all the way kind of like outside of the left adnexa there. All right. So just looking at some still pictures here. This is the fibroid. If we just look at it, just the fibroid and just focus on that. Now, I will say in this image here, you don't see the shadowing as much. However, you can see that it's a little bit calcified. And like I said in the beginning, when you do those sweeps, which are very important, you can see that it's branching off of the uterus. And you can also see that in this image here. that the fibroids here, and it's branching off of the uterus here. Okay, and now we have submucosal fibroids, which to me is just super problematic. All of them can be problematic, but submucosal can be much more of a pain. So submucosal fibroids develop in the muscle layer beneath the womb's inner lining and or grow into the cavity of the womb. Many fibroids will not present any symptoms, but a submucosal fibroid has several troublesome side effects, so much so that it can affect a woman's quality of life and fertility. So with submucosal fibroids, since they are distorting that endometrial lining, that's the lining that sheds every month for your period, and of course where the embryo will plant itself if you're once you're conceived. So sometimes the submucosal fibroids will either push on that lining, or like I was saying in the beginning, like I call it intracavitary, can be right inside that lining. Now, if you have something in that lining, it just causes a tremendous amount of bleeding. And of course, if you're trying to get pregnant and it's something already there blocking it, it can cause some women to have recurrent miscarriages. So let's take a look here, see what I'm talking about. I got a video here. So before I start the video, I want you to see that this is the uterus here. This is the uterus right here. And you can see that right now, this is already a fibroid just lodged right in that lining. Right here, just circle. I can see a little shadowing here. I'm going to do some sweeps. Perfect picture there. You have the fibroid right there in the middle of the endometrium, which is this hyperechoic area here. It's just lodged right in that area. Like I was saying earlier, you can put, okay, this is a submucosal fibroid, and that's exactly what it is. I like to use, if I see a fibroid located directly into the lining, I will put in my report intracavitary, so the doctor know that it's not it's not anteriorly sitting on it, it's not distorting it, it's inside of the actual lining. I'm not really sure how many other techs do that, or if people just use submucosal. I'm not really sure, but that's what I like to do, and that's what worked for the physicians that I work for. So if you can see some really good shadowing there to confirm that this is a fibroid and not a polyp. All right, so we got some still pictures here. This is the fibroid right there. And then this is another patient with fibroid lodged right in that lining. And you can see a lot of shadowing here and some calcifications for this fibroid. And remember, this is the submucosal fibroid. All right. IUDs. So for IUD placements, transvaginal ultrasounds can simplify the procedure and minimize risk. Physicians can encounter complications during the insertion process, including expulsion, displacement, and perforation. A displaced IUD can cause pelvic pain, abnormal bleeding, and or spotting, severe cramping, abnormal discharge, or fever. It's possible for an IUD to come out of place without any signs. Some women may be asymptomatic and not feel anything if the IUD becomes out of place. So let's take a look at some good IUD placements. So again, this is the uterus here, and the IUD is always going to appear echogenic, very, very bright. And you want to make sure your IUD is at the top of the fundus there. We don't want to see any room there. We want it to be all the way at the top. Same thing here. You're going to see some shadowing also from the IUD. This was all the way placed to the fundus, and you can actually still see the strings of the IUD going all the way down towards the lower uterine segment here. So these are really beautiful IUD placements. Same here. This is a really beautiful IUD placements, and you can kind of tell, like, different IUDs look different on ultrasound. So the Mirena will look different from Kyleena and look different from the others. So Paragard, to me, looks significantly different from the others. And then you can see the IUD is placed towards the fundus. You can see the strings going down here. And then this is in the transverse plane here. And what you want to see, is the T shape. So we want to make sure it's not crooked and that it's perfectly symmetrical. And of course, if you have 3D images, those are always cool too. All right, so we're going to look at some not so great placements here. So in this image here, you can see that the IUD pretty much is all the way up to the fundus. I did go transversal in this patient, but you could kind of tell from just looking sagittal that the T in this image is just crooked. Like it's not straight. Sorry. It's not straight. It's already sideways. It's a little crooked. Patient was coming in. She was having some abnormal bleeding and some spotting, I believe, after sex. So it was just very painful for her. And with this patient, now the patients that have IUDs that aren't placed all the way to the fundus, which is what this is, they typically don't have many symptoms sometimes. They just come in and get it checked to make sure it's in the right place, and we end up seeing this. So you see the IUD is placed in the lower uterine segment mostly. And you can see where I'm measuring here, it's like almost 2 centimeters away from the actual uterine fundus. So that's too low. So you risk the IUD, coming out. So that, of course, will have to be adjusted. All right. So polycystic ovarian syndrome, also known as PCOS. Polycystic ovarian syndrome, commonly known as PCOS, is an endocrine disorder that produces anovulation. Sonographic findings of PCOS may reveal bilateral ovaries that contain multiple small follicles located in the periphery of the ovary. The follicles produce a sonographic appearance of a string of pearls. The size of the ovaries may be normal or enlarged. Sonographic criteria for diagnosis of PCOS include presence of 12 or more follicles measuring 2 to 9 millimeters or increased ovarian volume greater than 10 milliliters. So we're going to look at some ovaries here in the transverse plane. So already before I even start the video, you can kind of see what we say, the string of pearl appearance. So what that means is typically you look at an ovary as normal in size and you can see the follicles just kind of randomly placed. But with PCOS, what's interesting is that you can see all of those little cysts just around the edge of the ovary. So you can see right there, all of these little cysts around the edge of the ovary. And in this image, these ovaries, you can just tell they're large, way more enlarged than they should be. And once again, I want to show you that string of pearl appearance there because that's very, very important. Especially on this one, you can see they're all around the edge there. And it's both ovaries look exactly the same. So here we got some still pictures. Of course, different images, different patients. So again, that string of pearl-like pattern there that you can see. This is enlarged. And same here. This one looks a little bit more elongated, but you can still see the same pattern. You see no follicles in the middle there. It's just clear as day. Then all the cysts are just kind of around the rim there. Classic case of PCOS. Okay, so let's talk about first trimester pregnancies. So, viable pregnancies. What we look for: a gestational sac, of course, the appearance of an anechoic fluid collection surrounded by an echogenic ring in the fundal region of the endometrial cavity is the first sonographic evidence of an intrauterine pregnancy. So when you first come, we should already see that, dark anechoic circle there. That's the first thing we're going to see. Then the yolk sac. Yolk sac appears as a round anechoic structure with the echogenic rim. The yolk sac should be visualized around 5 to 5.5 weeks. Normal measurements between 2 and 6 millimeters. Embryo, of course. The embryo should be visualized by 6 weeks gestation based on LNP. Faint flickering of this structure, which represents early cardiac activity, may be seen on real-time sonography. All right. So here we have a very early pregnancy. I think this patient was about 5.5 weeks. you can see the flickering there. This is a very early pregnancy, but I already can see a very strong heartbeat right there. And then you can see the yolk sac here. So that's what we want to see. So first is the anechoic fluid, which is the gestational sac, which is here. This is the first thing you want to see with the echogenic rim here. And then we have the yolk sac. Of course, after the yolk sac, we see the embryo with flickering. Always have to see the flickering. It's the most important part, right? All right, so here we have some more pictures of the gestational sac with the yolk sac. It's perfect yolk sac here. And then here is an embryo. These are viable pregnancies. All right, so now let's talk about a divided ovum. A divided ovum, which is also referred to as an embryonic pregnancy, is normally diagnosed when an empty gestational sac is visualized measuring 25 millimeters with no evidence of a yolk sac in embryo. So the measurement of the gestational sac is very, very important. Of course, if you have a tiny little gestational sac and it's measuring so small that it's not even generating what the pregnancy the patient is in, then of course we know we need to wait. And but sometimes if that gestational sac is big, and exceeding 25 millimeters, we're a little concerned if we don't see at least a yolk sac, right? So here's the image here of a divided ovum. Here you don't see anything. This is it's like perfect yolk sac. Just looking through, I don't see. Perfect gestational sac. Sorry, I don't see a yolk sac or a fetal pole in sight. So, of course, I think with this patient, we did end up bringing her back to make sure, and it looks the same. Absent fetal heart rate. A primary role of sonography in this evaluation of pregnancy in the first trimester is confirmation of pregnancy. If the crown rump length measures 5 millimeters and the cardiac activity is not seen, the diagnosis of embryonic death can be made with confidence. So there are times where we may see everything, right? We see the gestational sac, which is first, then we see the yolk sac, and then we see the embryo. However, you don't always see the heart rate. If there's not a live birth, you won't see the flickering. Now, the flickering, like I showed you from the baby that was the fetal pole that was only 5.5 weeks, you should see that visually. It won't be difficult to see. You will be able to see it pretty clearly. So if we don't see it, and sometimes, especially in the beginning, you can feel like your eyes are playing tricks on you, you can also use color doppler and M mode to make sure that, there is indeed absent fetal heart. Right, so I'm going to play this video here. Is it playing? Oh, there we go. Okay, so I'm scanning here, and if you just look, we don't see any flickering here. You want to see the heart rate moving about right there. But I'm just looking in different planes to see if I can pick something up. And I also see the yolk sac back there. It's enlarged as well. So that's also a clue that something is not right as well when you see a enlarged yolk sac. So as said before, I do still like to make sure with color doppler and M mode that I'm not picking up on a heart rate. So even though I don't visually see it, I still want to always make sure I put that color box on it to see if it'll pick up the rhythm of the heart. Because if the heart rate is going, and for whatever reason you just can't see it, if you put on color, you'll then be able to detect it. So I put color on this embryo here just to make sure. And of course, in this area, well, in general, you're not seeing really anything. It's supposed to be a rhythm, like flick, flick, but there's nothing there. So that's how we determine absent fetal heart rate. All right, so let's go on to something like ectopic pregnancy. So ectopic pregnancy is a pregnancy located outside of the fundal portion of the intrauterine lining. The most specific sonographic finding diagnostic of ectopic pregnancy is an extrauterine gestational sac that may or may not contain a living embryo. The uterus is usually consistent with the normal non-gravid uterus. An ectopic pregnancy may also be seen as a complex adnexal mass with an echogenic adnexal mass, and increased vascularity. The area will be immobile with pressure and may cause extreme pelvic pain or discomfort in the patient. So ectopic pregnancies, they can be super obvious or they can be really tricky depending on the stage you get the patient, especially early on, because if you're not careful, you can miss it. So with the ectopic pregnancies, you have to make sure that if someone's coming, they're having pain, they have a positive pregnancy test. Of course, we want to make sure that gestational sac is in the right place, right? It has to be inside the uterus, right where it's supposed to be. Now, if we see that they're supposed to be, 7 weeks, 6 weeks, 8 weeks, whatever, based on the LNP, and we don't see a gestational sac at all, and their HCG levels are pretty high, then, okay, now we're raising a red flag, because these women do have pain, but some women, I've encountered women that didn't have any pain, to be honest with you. So just, be aware of that, because I know when I first learned, they said, they'll be in so much pain, but I guess depending on the stage, some women don't feel pain until later. So we want to make sure we see a gestational sac in the uterus. So if we don't see that gestational sac, automatically we're surveying, right? So I survey, and then we make sure we don't see any ectopic. So with the ectopic, it will appear as like a mass. Like it will appear as a mass. It will have that anechoic area and that echogenic ring most times. And what's really important to use for this is color. So we like to see that. And if you can, sometimes if the patient's in a lot of pain, it's very difficult. But for those patients that aren't in pain, we like to kind of push down on the abdomen to see if the area is moving or if it's just kind of staying the same, which is a telltale sign if it's not moving. So here is an example of an ectopic. So this is like the left ovary here. And then you see this mass that's just on the left side of the adnexa here. And it's like, well, what is that? Then I do a little bit more research. I measure. And of course, like I said, it has that echogenic area and a little anechoic fluid in the center. And it will also be vascular. This particular patient, I did not get a video, which I was so sad about. But, sometimes when the patients they're going through enough, and, you're worried about making sure the patient's okay. So, of course, I wasn't getting, I didn't get so many things. I just took so many images. I think it was an emergency patient as well. But this is kind of how it would classically look. And so this is a big one. Sometimes they're really tiny. That's why I said these can be very tricky. And you have to be careful. And that color is very important in pushing on that abdomen if the patient is not in too much pain. So that is it. Wow, that's it. Yep, that's it. And Shirley, are you still there?
Thank you so much. Oh, Iikia, that was so fascinating. Thank you for walking us through all of those each of those conditions, and just very detailed look into what one should be looking for. We'd love to open this up to questions now. So please go ahead and type your questions into the Q&A chat box at the bottom of your screen. In the meantime, while we wait for those, what are some common questions that you get, Iikia, from this particular tool? Because I know that there is some, this is a very specific tool, and what are some of the sort of things that people should know?
So a lot of women want to know exactly what we can find with ultrasound, which I like to tell them pretty much everything. I think lately my most common questions are about fertility. Like if they're trying to conceive and they just don't have any luck, can we find out if they're fertile or not? That's kind of one of the biggest questions I've been getting lately. And the answer to that is yes, because we can look on the ovaries and see how many follicles a woman has. We can also look at the endometrial lining. The endometrial lining changes throughout the month. So we can bring a woman in periodically and see if that's changing as it's supposed to. And if she's ovulating, because we ovulate every month off of one ovary, if we can see that she's ovulating, then we can pretty much let her know if she's fertile or not.
Oh, wow. And is this a question of like going to your specific provider, or how would patients know that? How would they be aware?
So it's different because normally women will kind of go to like when they go get in vitro or something like that. But nowadays, OBGYN offices will kind of take on a patient, not as extensive as an in vitro clinic, but we will still kind of like monitor you to make sure you're at least ovulating. So if you're having regular periods during your ovulation cycle, hey, can you come in and get an ultrasound? And let's see if you're ovulating, how your lining looked, and things like that. And we just do it that way. And that way, that kind of stops you from having to go to an fertility clinic unless you just don't end up getting pregnant for whatever reason. But typically nowadays, we're just trying to handle that on our own at the office.
Wow, that sounds almost, that's newsworthy. That's really fascinating.
Yeah, I mean, women don't know that because they're scared to ask the doctor because they think they have to go to a fertility clinic. But before you go to a fertility clinic, you can just ask your OBGYN, and we can do hormonal lab work. We can do an ultrasound. There's so many things we can do before you have to take that route because insurance doesn't always cover the fertility clinic.
And that's right. Great. Well, we don't have any questions that have come in just yet. I'm trying to think, are there any other, I mean, the tool itself is pretty powerful. How did you end up choosing this tool?
So for me, I wanted to go into medical, and I just did not want to be a nurse. No offense to my nurses, I just did not want to be a nurse. But I seen imaging, and I just like, oh, I think that's something I would like to do. I went into school, and I actually did not want to go into OBGYN. And I remember my teacher telling me, everyone that doesn't want to go into OBGYN ends up in OBGYN and vice versa. Like, she was right. Because I'm like, I don't want to scan babies all day. I don't want to do this. But when I graduated from school, I just seen so many defects that the pediatric babies were having with the heart and everything like that. And some things like that could be caught in ultrasound and OB, like when the baby is in mom's belly, like we could catch that then. So it kind of sparked the interest there. And that's why I kind of went into OBGYN first, mainly because I wanted to be a part of seeing if I can catch any pathology early so that baby can have a surgery and have a better risk of, living and things like that, especially with the heart. So that's how I ended up here. But ultrasound is truly amazing. Like, we can find out, and this is just based on, we're just looking at reproductive organs. It goes way beyond that.
That is fascinating. And thank you for also that background on just what you end up choosing. Very important, especially because women, as we know, are not served sometimes in the ways that they need. Okay, we do have one question that came in from Dr. Natalie Vargas. When you don't have any of the criteria for ectopic on ultrasound and blood, what do you do next?
Okay, so we don't have the criteria. First, we use the patient, just what they're saying. So, like I said, sometimes they don't have pain for ectopic, but if they have pain, that's the first indication. Like, okay, do you have pain? When did you miss your period? Do you think you're pregnant? That's our first questions there. So after that, when we start scanning, if they are having pain and they have missed their period, those are the only two we really have to go by. We don't have lab work. Because sometimes when I'm scanning a patient, especially if it's an add-on, it's an emergency, I don't have the HCG levels. I have no clue. I just know that the patient is supposed to be pregnant. So when I scan them and they give me an LMP and I don't see anything in the uterus, I don't see a gestational sac in the uterus, I automatically think in my mind, rule out ectopic, and I start looking for an adnexal mass. That's pretty much it. It's really about the history, the word of mouth from the patient. Are you supposed to be pregnant? Even if they say, "Oh, I'm not supposed to be pregnant," I don't know if I'm pregnant. Some patients have no idea. They can lose a period and not have a period in 2 months. They have no idea. They may have PCOS, so they don't have regular periods. But they may have pain. They say, "Okay, you have pain. Let me take," because that's still like, if you have PCOS, you're not supposed to be having pain. So always scanning for for an adnexal mass.
Wow, thank you. And then Dr. Vargas added this to beta, if the beta is high, but you don't see it on the ovaries or UT, I guess, what do you...
Oh, that's actually very common. So, because like I was saying earlier, with the topic is tricky. So it may be so small and it may be too early that you may not see it at first. So what I would do, and we've had to do this at the office, not often, we will have to repeat it. We will have to like literally monitor that patient, like repeat it in 2 days because it grows rapidly. So it's like, okay, let's repeat in 2 days or 3 days. And then something will pop up if it's in a topic. Thank you for that question.
Good.
Shirley, are you there?
Oh, sorry about that. I was talking and I'm not sure how much of that you heard.
I didn't hear anything. I'm like, where's Shirley?
I was talking to myself over here.
That's funny.
I was just saying, the first thing I said was Dr. Vargas had said that you had answered the question, and I think that she was referring to even the first part of your answer. So that was great. Thank you for the extra information. Yeah, at this time, I was also saying that we don't have any other questions that have come in, but how would you like us to be able to get in touch with you? We can also send your information to all of our registrants, but if you'd like to, on your, I could certainly share it with everyone through our chat.
Yes. So I would love everyone to follow me on social media because I do videos like this all the time.
Great.
My social media handle is sonographer, fit, FIT, mom, MOM. That's my social media handle for Instagram and TikTok. I talk about things like this all the time and I answer questions too. I'm very active on my social media. So whatever anyone wants me to talk about, I do. I do like to talk about things on a very like basic level at first because I want the average woman to be able to understand what their pathology may look like if they're diagnosed and they'd be able to see how it actually looks and how it affects them.
Wonderful. And if you wouldn't mind spelling that out, I'm going to go ahead and put it in the chat box for everyone to copy and paste, and I'll make sure to follow you too. Can you spell that out for us?
SONOGRAPHITMOM.
Excellent. Sonographer mom. So great. I've just sent that to everyone here. I hope that you received it and that you'll be able to copy and paste it somewhere and to go right away to your preferred social media platform to follow Iikia. So that's for more information. Well, thank you so much, Iikia, for a really wonderful and edifying presentation tonight. And thank you everyone for joining us. We did record today's webinar, and we're going to be emailing out that recording sometime in the next week. We'd love to get your feedback via our survey that's going to pop up on your screens shortly. And again, thank you for joining us, and we look forward to seeing you on our next webinar.
Have
a great evening.
Bye.
Bye.